Welcome to the culture of healthcare, evidence-based practice. In this part, in this session, we'll continue our focus on the culture of healthcare. We'll address the expectations placed on professionals working in healthcare settings, and we're going to explore how care is organized within a practice, the privacy laws that shape patient interactions, and the professional and ethical issues that arise in the workplace. For clinical engineers, these themes are especially important. Working in healthcare means more than managing technology, it requires understanding the culture that surrounds it. Engineers must navigate organizational structures, respect privacy requirements, and uphold ethical standards, all while ensuring that medical devices and systems support safe and effective patient care. So, here are the objectives for evidence based practice in clinical engineering. And again, it's define the key tenets of evidence based medicine and its role in the culture of healthcare. And we said evidence based medicine emphasizes integrating the best available research, clinical expertise, and patient values. In clinical engineering, this translates to designing, selecting, and maintaining technology based on proven outcomes, not just manufacturer claims or tradition. For example, EBM shapes how hospitals adopt medical devices by demanding evidence for safety, reliability, and clinical impact before widespread implementation. And we're also going to look at how to construct answerable clinical questions and critically appraise evidence answering them. So clinicians may ask, does this treatment improve survival? A clinical engineer might reframe the question, does this imaging system detect abnormalities as accurately as the standard of care? Or does this infusion pump reduce dosing errors? And these answerable questions allow engineers to evaluate devices against objective criteria, critically appraising vendor data, regulatory studies, and independent research. Let's present some key definitions of evidence based medicine and describe how EBM is applied in practice. One useful way to think about EBM comes from a diagram published by Moreau and colleagues in 1997. This framework helps us put evidence into proper context. It shows that evidence is just one of three essential aspects that go into making a clinical decision. The first aspect is the research evidence itself, the results of randomized controlled trials, systematic reviews, and other studies. This is the scientific foundation of evidence based medicine, but evidence alone does not make the decision. The second aspect includes patient and physician factors. These might involve cultural beliefs, personal values, experience, and education. Patients may have strong preferences about their care, and their physical response to treatment or medications can shape what's possible. Physicians likewise bring their own expertise and limitations, especially in rural or resource limited settings where not all services are available. The third aspect is constraints, and these can take many forms: formal policies and laws, professional standards, and community expectations. Time is often a constraint. For instance, when a patient is acutely ill and there isn't time to wait for more testing or consultation. Financial and reimbursement issues also play a role since what's covered by insurance often shapes which treatments or tests are realistically available. And let's consider this framework and what it means for clinical engineering. Engineers also make decisions that balance these three aspects. So, when it comes to evidence, engineers draw on device trials, performance data, and safety reports to assess technologies. When it comes to people factors, engineers must consider the skills of a staff, the training required to use equipment safely, and the preferences or needs of patients, such as designing accessible devices for diverse populations. And when dealing with constraints, engineers face real world limits as well, from regulatory requirements and hospital policies to time pressures during emergencies and the cost of acquiring or maintaining equipment. In other words, just as physicians must integrate evidence, patient values, and constraints, so too must clinical engineers. And their decisions about technology adoption, technology maintenance, and use are never based on evidence alone. They are shaped by the culture realities of healthcare practice. There are many resources available to support the practice of evidence-based medicine. These resources not only explain how to apply EBM in clinical settings, but also help demystify the ideas and techniques that sometimes feel complex at first. One classical resource is the book by Strauss and colleagues, often informally called the Sackett book. Right? This title honors David Sackett of McMaster University, who authored the original book on evidence-based medicine before his retirement. Now, in its fourth edition, the Strauss volume continues to be a cornerstone reference for clinicians. Another set of resources comes from Gordon Guyatt and colleagues, also with roots at McMaster, and their work began as a series of articles in the Journal of American Medical Association under the heading User's Guides to the Medical Literature. And these articles eventually grew into two books, both updated in 2015 to their third editions. The first, A Manual for Evidence-Based Clinical Practice, serves as basically the encyclopedia reference covering the full scope of EBM methods and applications. And the second, Essentials of Evidence-Based Clinical Practice, Essentials of Evidence-Based Clinical Practice. That's more compact. It's a handbook designed for quick access to the most clinically relevant material. In addition to books, there are numerous websites that provide tools and learning materials for EBM. So a few examples would be www.cebm.net, which is the Center for Evidence-Based Medicine at Oxford University. There's www.cche.net, which is the Center for Clinical Health Evaluation. And I won't read everything, but www.nettingtheevidence.org.uk. Again, it's a curated collection of EBM resources and evidence links. Now, when we're talking about clinical engineering and how that's specific to EBM, evidence-based medicine, so while the above resources or references are widely used across healthcare, clinical engineers also have their own evidence-based tools and databases that guide decision making around medical devices and technologies. And there are some associations out there that actually help support providing that data. ECRI Institute is something you might have heard of. They provide evidence-based evaluations of medical devices, health technologies, and safety alerts that are often used by hospitals to guide purchasing and risk management. If you're familiar with the website, the FDA MAUDE database, that stands for the Manufacturer and User Facility Device Experience. It's a publicly accessible database of adverse event reports that involve medical devices. Engineers can search this to identify patterns of harm or evidence of device failures. We also have the HTA, the Health Technology Assessment Report. There's also the WHO, the World Health Organization's Medical Device Technical Series. Quite a few things out there for the engineering community to take part in EBM in the healthcare organization. Evidence-based medicine has been evolving for many decades. A 1999 paper by Hirsch described the early model as first-generation EBM. In this approach, the clinician was expected to personally find and critically appraise evidence at the point of care, and the idea was that a physician or any health professional would identify a question, search for relevant articles, analyze the study design and statistics, and then immediately apply the findings to patient care. In theory, this is ideal. In practice, it quickly became clear that the process was unrealistic. Busy clinicians rarely have time to stop mid-shift to appraise a randomized controlled trial or do all the training to dig into the complexities of research design or statistical interpretation. This gave rise to the next generation of EBM, the focused shift toward synthesizing and synopsing evidence so that it could be prepared or pre-appraised and organized and made readily available instead of every individual clinician redoing the critical appraisal. Experts can now produce systematic reviews, evidence summaries, and guidelines that clinicians can use or can access even online and in real time. And the goal, timely, up-to-date information that supports decision making at the bedside. Slauson has taken this even further, arguing that the emphasis should not be on teaching every clinician how to master research methods. Instead, the focus should be on information management skills, and that is how to seek out, filter, and apply the best information efficiently. So, for clinical engineers, this evolution has direct parallels. In the early years, an engineer might have been expected to dig through raw technical papers, safety reports, and regulatory filings for every single device decision. Today, evidence synthesis plays a growing role. Organizations like ECRI, HTA groups pre-appraise evidence on devices and technologies, providing engineers with systematic reports that speed up decisions. That doesn't mean engineers don't need critical appraisal skills. They do. But just as clinicians are now trained in information seeking rather than full scale statistical analysis, engineers are increasingly tasked with finding and applying high quality summaries of evidence to make decisions about technology, adoption, maintenance, and safety. The shift from do it all by myself to access synthesized evidence reflects a broader cultural movement in healthcare. So, supporting professionals with curated knowledge so they can focus their expertise where it matters most on patient care and system safety. Another useful perspective on evidence comes from Brian Haynes, whose name will appear throughout this unit. He suggests that when we apply evidence or when we evaluate a treatment, diagnostic test, or technology, we are really asking three core questions. First is, can it work? This is a question of efficacy. Efficacy studies are typically randomized controlled trials carried out under ideal conditions, and participants are closely monitored and extensive data is collected. And these studies tell us whether a treatment or intervention can work when everything goes right. A clinical engineering example, so a new imaging system may show excellent resolution in laboratory testing, or a tightly controlled trial demonstrating that it can detect small lesions under perfect conditions. All right, so the next question is, does it work? This is the question of effectiveness. So effectiveness studies examine whether an intervention works in the real world outside of those ideal trial conditions when used by a broader range of providers and patients. And in clinical engineering, there's a similarity, right? So that take that same imaging system that may perform differently once deployed in a community hospital where variations in staff training, patient populations, and workflow affect outcomes. So engineers help measure whether the device delivers reliable results in day-to-day use. And the third question is it worth it? So this is a question of value. So cost benefit and cost effectiveness studies weigh the benefits of an intervention against its financial resource and logistical costs. So the question is not only does it work, but also is it worth the investment compared to alternatives? In clinical engineering, a good example would be a hospital may determine that while new imaging systems provide slightly sharper images, the cost is far higher than comparable devices. Um, so engineers may advise whether the marginal improvement justifies the expense, especially when budgets also must cover staff training, service contracts, and maintenance, and the cost of ownership is what I call it. So taken together, these three questions can it work? Does it work? Is it worth it? Help guide evidence-based decisions in both clinical medicine and clinical engineering. And they remind us that evidence is not just about performance in theory, but about real-world outcomes in value and practice. Another way to think about evidence is to consider the hierarchy of evidence. One influential approach comes from Brian Haynes. His model began as the 4S model, the simplest version, and later expanded to the 5S and then 6S. Even so, the 4S framework remains the most widely recognized and practical. Not to get off tangent here, but if you buy the video for abdominal muscles and 13 minutes and someone sells the next one abdominal muscles in 12 and so forth, it kind of feels like the same thing. But anyway, let's back to lecture. So, at the base of the hierarchy are studies, original research published in medical or engineering journals, and these provide the raw data. For example, a single trial might test whether a new blood pressure monitor is accurately or is accurate compared to a standard device. Because many studies exist on common conditions or technologies, we need to organize them, and that brings us to the next level, which is synthesis. So the best synthesis are systematic reviews. Sometimes we call those evidence reports, and these bring together multiple studies and it analyzes them as a whole. For instance, a systematic review might combine dozens of trials comparing different ultrasound systems to determine which consistently performs best. However, systematic reviews can be lengthy and complex. Again, busy clinicians and engineers, they need quick takeaways. That's where synopsis comes in. Synopsis are evidence based summaries or abstractions that distill the main findings from a comprehensive review to concise, actionable points. For example, a synopsis might tell us a device has a higher accuracy but requires longer training. Device B is more user friendly but slightly less precise. At the top of the hierarchy are systems. Here, evidence is not just summarized, it's integrated into decision making tools. So, this is actionable knowledge. And in clinical practice, that might mean an electronic health record system that prompts a physician with guideline based recommendations. In clinical engineering, it could mean a device management system that automatically flags recalls, that provides evidence based maintenance intervals, or suggests technology upgrades based on published outcomes. And in engineering psychology, which is another subject that I won't go into here, a lot of this has to do with, with what's called cognitive load. And so, again, not to go into psychology in this lecture, but something you might want to look into if you're interested in what we're talking about right now. Anyway, back to this. Looking at the Forest model, it shows how evidence evolves from raw data to structured guidance so that it can actually inform real world decisions. And for clinical engineers, understanding this hierarchy means knowing where to look for evidence, how to interpret it, and how to integrate it into technology and workflow decisions. Where does the evidence come from? And depending on the level, there are different types of evidence. And in the slides that follow, we discuss a number of these in detail. Starting at the foundation of the evidence hierarchy, we have studies. This evidence generally comes directly from the medical literature, most often by accessing databases such as Medline and others similar to that, PubMed, for example. But Medline contains bibliographic references to millions of journal articles covering a vast range of medical and health sciences research. The most common way to assess Medline is through PubMed, which is freely available and maintained by the U.S. National Library of Medicine. PubMed allows clinicians and researchers to search for original studies, filter them by type, and begin the process of critical appraisal. And at this level, relevant studies are gathered from the literature and then analyzed carefully. To do this, clinicians use formulas such as relative risk, sensitivity, specificity, odds ratios, and number need to treat, so NNT. And these statistical measures help translate raw study data into meaningful information that can uh, guide decisions. So for clinical engineers, the same principle applies. Evidence at the studies level may come from original device trials published in engineering or clinical journals. It could be FDA filings that include safety and performance data. It could be manufacturer white papers or our pilot studies on new technologies. And just as clinicians use risk ratios or sensitivity calculations to judge a treatment, engineers may apply metrics such as failure rates, mean time between failures, or the MTBF, They can look at accuracy, error rates, or sensitivity and specificity of diagnostic devices. And these measures allow engineers to critically appraise whether a device performs as claimed and whether it is suitable for adoption into practice. So, in short, at the studies level, both clinicians and engineers are digging into raw research, carefully analyzing and interpreting data to lay the groundwork for higher levels of evidence. The next level in the hierarchy is synthesis. And this level typically consists of systematic reviews or, in some cases, evidence reports. And these are comprehensive, exhaustive reviews of the data on a given topic. Often, a meta analysis is used at this level. So, a meta analysis combines the results of multiple similar studies into a single pooled analysis. For this to be valid, the studies must be methodologically comparable, meaning they use similar interventions, similar patient groups, and compatible outcome measures. Tools such as statistical tests for heterogeneity help determine whether combining studies is appropriate. For example, if 15 different clinical trials have been conducted comparing surgical and medical treatments for back pain, which I'm experiencing right now, or for a specific cancer, which I hope I'm not experiencing right now, and the interventions and the populations are sufficiently similar, those trials can be combined into a single meta-analysis. This pooled approach can reveal stronger or more reliable conclusions than any one trial alone. Importantly, meta-analysis isn't limited to treatments. It can also be applied to diagnostic tests, prognosis studies, and other clinical questions. Systematic reviews can be found in places like PubMed and now the retired PubMed Health. Right? So it was a database that specialized in systematic reviews exclusively. So today, databases like the Cochrane Library are considered the gold standard sources for high quality synthesis. And for clinical engineers, the same principle applies. We have systematic reviews that might evaluate the safety and performance of medical devices, such as infusion pumps, imaging systems, or ventilators across multiple hospitals and settings. So meta-analysis could pull device failure rates, alarm response times, or diagnostic accuracy metrics across multiple studies to provide stronger evidence for or against a technology. So there are organizations out there also that routinely produce synthesis reports on device and technologies, guiding hospitals in procurement and other safety decisions. And just as clinicians rely on systematic reviews to make evidence based treatment decisions, engineers rely on technology reviews and evidence based synthesis, to decide whether a device should be purchased, replaced, or integrated it into clinical practice. The next level in the hierarchy is synopsis. Synopses are concise summaries of information that is directly relevant to the clinical setting. They're designed to provide quick, actionable answers to specific questions. So, for example, if a clinician is treating a patient with low back pain, they don't want to sift through dozens of individual studies or even a lengthy systematic review. Instead, they need a summary that distills the best available evidence to clear recommendations. And synopses are often written as critically appraised topics or CATs. Right? These concise reviews summarize the evidence for a well-framed clinical question. They can be found in resources such as the book for clinical evidence or online tools like InfoPoems, which stands for Patient Oriented Evidence That Matters, and PIER, PIER. Um, so we have clinical practice guidelines that also belong to this synopsis category because they translate bodies of evidence into concise, practical recommendations. And at the highest level of the hierarchy, we have systems, and these are clinical decision support systems that are often integrated into electronic health record systems. Systems are designed to present evidence to the clinician at the point of care, in the exact context where decisions are made. And ideally, the evidence doesn't just exist in a book or a database, it's woven directly into the workflow, guiding choices in real time. And for clinical engineers, these levels are just as important. So synopsis in engineering is evidence-based technology briefs, executive summaries for safety alerts, or summarized findings from health technology assessments. And engineers don't always need every raw study. They need a clear, concise answer about whether device A or device B is safer, more reliable, or more cost-effective. Systems in engineering, integration of evidence into computerized maintenance management systems, device dashboards, hospital IT systems. So, for example, a CMMS that automatically pulls recall notices from FDA databases or flags evidence-based maintenance schedules to ensure that decisions about technology are informed by up-to-date knowledge at the point of use. But in short, synopsis distill the evidence into manageable, usable chunks while systems embed that evidence into a day-to-day decision making. So together, they represent the most efficient way of applying evidence, whether in treatment of patients or managing the technologies that make modern healthcare possible. How is evidence-based medicine applied in practice? Well, the process can be broken down into several steps. And let's talk about the first, a how to phrase a clinical question. Right? The phrasing of a clinical question. So the first step is to carefully phrase a clinical question that is both pertinent and answerable. For example, a physician might ask, does this medication improve recovery rates for patients with pneumonia? A clinical engineering parallel might be an engineer might ask the following: does this new patient monitoring system reduce alarm fatigue compared to our current system? So, a quick aside again, this kind of reminds me of Sherlock Holmes when someone asks a question and he says, that's the wrong question to ask. And then they'll reply, well, what is the right question? And so, knowing the right question is very important. If you don't have the right question from the beginning, you're going to go off somewhere. You're going to find an answer to something that you didn't need to know. So, continuing back with the lecture, I'm sorry. So, identifying the evidence. Once the question is framed, the next step is to identify the evidence that can help answer it. And this often means searching databases such as PubMed, systematic review repositories, or device performance registries. Engineers may gather data from the FDA, or publications, or hospital equipment databases. Critically appraise the evidence is the third step. So, this third step is to critically appraise the evidence, meaning evaluating whether the study design, methods, and results are even reliable. Are they valid and applicable to the patient or the situation at hand? So engineers might assess whether study findings apply to their hospital's context, asking, was this device tested in similar patient populations? Were the staff trained to the same level? Do the reported performance metrics align with what we've observed locally? So we'll spend less time here discussing the details of critical appraisal, though we will return to it later when we examine interventions more closely. But for now, remember that all the references listed earlier, such as Sackett and Guyot books, they provide detailed frameworks for critically evaluating evidence. And together, these steps, asking the right question, finding the best evidence, and critically appraising it, um, form the foundation of evidence-based medicine. And importantly, the same logic applies to evidence-based clinical engineering, where the questions, evidence sources, and appraisal tools may differ, but the principles remain the same. And in the next few sessions, we will be diving and sticking more to the healthcare side, but this is actually for the benefit of you clinical engineers out there because it's important for you to understand the environment again in which you will be working. And our job is to embed ourselves into the healthcare environment without disturbing what they do. Phrasing the clinical question. So let's discuss a little more in detail about phrasing the clinical question. One useful way to think about clinical questions is to distinguish between background questions and foreground questions. This is something I teach my communication students. So, background questions are general questions that arise in patient care. These are usually answered without needing the full evidence based medicine process. So, for example, a clinician might ask, what are the common causes of pneumonia? Or what is the mechanism of action of insulin? These questions are typically answered by consulting a textbook, a trusted reference, or a classic review article rather than systematic review. In clinical engineering, the engineer might ask, how does an MRI machine generate images, or what are the standard safety limits for electrical leakage in patient monitoring equipment? And these are background questions, basic knowledge that can be found in technical manuals, standards documents, or reference materials. Now, foreground questions, on the other hand, are the ones we ask when we need knowledge about managing a specific disorder or making a decision about a test or treatment. And these questions are directly tied to patient care and are best answered using evidence based medicine techniques. For example, in adults hospitalized with pneumonia, does a combination antibiotic regimen reduce mortality compared with a single drug? And for clinical engineers, it might be in an intensive care unit, does monitoring system A reduce false alarms compared with monitoring system B? For neonatal imaging, does portable ultrasound provide diagnostic accuracy compared to MRI? And these are foreground questions that require gathering and appraising evidence, not just looking up background facts. So, again, background questions build foundational knowledge, while foreground questions drive evidence based decisions. And clinicians and engineers both need to be able to tell the difference because it shapes when we rely on general references and when we turn to the structured process of evidence based medicine. Taking a closer look at background questions, these questions often ask for general information that isn't specific to a single patient case. For example, what causes pneumonia? What are the usual causes of pneumonia? Bacteria, virus, or even chemical pneumonia? Are there other possible causes? And at what stage of type 1 diabetes do complications usually occur? Or in what order do complications like neuropathy, heart disease, and kidney failure typically appear? These are background questions, broad, general knowledge that we usually answer through textbooks, traditional reviews, or foundational references. But the line between background and foreground questions is not always clear. For instance, if there are new causes or emerging factors related to a disease, you may want to know about them as well. Depending on the context, this could be seen as either background knowledge or foreground knowledge. And your level of training also influences how you frame a question. So, for specialists, much of the background is already familiar, so they may focus more on foreground questions. For a student, nearly everything is new, so even basic information might feel like a foreground question. And the key point is that although the distinction between background and foreground questions can be blurry, learning how to recognize and phrase a clinical question is essential to finding the best available evidence. So for clinical engineers, it's the same. Same thing applies. Background questions are are things like, what is the standard range of oxygen saturation measured by a pulse oximeter, or what are the basic steps in calibrating an infusion pump? As where foreground questions might be something like, does pulse oximeter model A perform more reliably in patients with darker skin pigmentation compared to model B? And this is a real issue here, not just an ideal, case. So does a new calibration protocol reduce error rates compared to the current standard? So while the distinction may shift depending on experience, context, and purpose, understanding whether you're asking a background or a foreground question helps you target the right type of evidence. And With that, we're going to turn to foreground questions. I want to talk to you about the foreground questions and what's called the PICO framework. So first, foreground questions have 3 or 4 essential components, and a helpful way to remember them is this PICO acronym, PICO. And P is for the patient or the problem. I stands for intervention, such as a treatment, diagnostic test, or a device. Again, just an intervention. The C is for comparison interventions, if it's applicable, and O is for outcome. A complete foreground question identifies these elements. For example, in medicine, when you're looking at the P, patient problem, you have you have an elderly patient with congestive heart failure where the heart is again not pumping effectively. The intervention I would be beta blockers. A comparison, again, the C part for PICO could be looking at the effects of placebo or no beta blocker. And then the outcome, which is the O in PICO, is the reduced morbidity and mortality without excess side effects. And this structure allows researchers to frame a question in a way that can be answered with evidence, ideally through a randomized controlled trial, an RCT. We'll talk much more about those later. In treatment questions, outcomes focus on effectiveness compared to control. In diagnostic questions, the intervention is the test, and the comparison is often a gold standard. In prognosis questions, we may not have a comparison group. Instead, we track the natural history of the disease. If we translate PICO into clinical engineering, again, which I think as clinical engineers, you should embed and dive yourself into the healthcare world and even function and use the same decision making tools that they do, so you're speaking the same language. But again, applying PICO to clinical engineering, if we're looking at P again as the patient slash problem, same P, we can be looking at intensive care units with frequent nuisance alarms causing alarm fatigue among staff. Intervention for our application, the I, would be maybe to look at new monitoring systems, right? Have a new monitoring system and just say system A. And then the C in this case would be great to do C. We can compare it to the current system, and we'll call that system B. So comparison is very likely in this scenario. And then O, the outcome, if we follow the PICO method. Does it have a reduction in false alarms? Does it improve staff response times? Are there fewer missed critical events? Another example for clinical engineering could be neonates requiring image. Would be the P, the patient problem, patient or slash problem. Neonates require imaging. And the I would be, the intervention would be portable ultrasound. And then the comparison could be to the MRI, which is the gold standard. And then the outcome, we can look at the diagnostic accuracy and speed at the bedside. So in both medicine and engineering, PICO helps transform a vague concern into answerable questions, which can then be investigated using the best available evidence. Let's talk about the 4 major categories of foreground questions. Most clinical questions fall into one of 4 major categories of foreground questions. So we have intervention, diagnosis, harm, and prognosis. So we'll start off with intervention, sometimes called therapy. And this category examines the benefits of an intervention, whether it's a treatment, a procedure, or preventive measures that improves an outcome. And the medical example would be, does a new vaccine prevent infection more effectively than the standard vaccine? A clinical engineering example would be, does introducing a new infusion pump reduce medication errors compared to the hospital's current pumps? Now, when it comes to the D for diagnosis, we look at diagnosis questions that evaluate tests, so how well they detect or rule out a disease. And these tests may include blood tests, imaging, or even physical examination maneuvers. So the medical example would be, is MRI more accurate than X-ray for diagnosing low back pain. Again, sorry, I'm mentioning the neck of I do have lower back pain, but it's a muscular, pull, so I'm fine. So, and the clinical engineering example would be, does a new pulse oximeter provide accurate readings across diverse skin tones compared to the current standard device? The H and the harm is sometimes referred to as etiology. Not that etiology means harm, but sometimes this section is referred to as etiology. Harm questions investigate causes of disease or injury, and this could be exposures, behaviors, or unintended consequences of an intervention. So, a medical example would be, does long term smoking increase the risk of lung cancer? A clinical engineering example would be, does poor alarm design and monitoring equipment contribute to alarm fatigue and patient safety risks? So let's look at prognosis. And prognosis questions ask about the likely course of a disease or long-term outcomes. And the medical example would be, what is the 5-year survival rate for patients with stage 2 breast cancer? And the clinical engineering example would be something like, what are the long-term survival and complication rates for patients with implanted cardiac devices after 10 years? In both medicine and engineering, these categories help structure evidence-based questions. Clinicians focus on treatments, tests, and disease outcomes, while engineers apply the same logic to technologies, asking whether devices are effective, accurate, safe, and sustainable in long term. Appraising the evidence. So, when we find a piece of evidence, such as a study, we begin by asking 3 core questions. Are the results valid? Was the study designed and conducted in a way that minimizes bias and ensures reliability? Are the results important? Do the findings show that a treatment, test, or intervention is truly efficacious, that it has a meaningful effect? And can the results be applied to patient care? Can we reasonably use the findings with the specific patient population or context we're working in? It's also important to consider applicability. If a study was conducted in a different age group, gender, or cultural context, the results may not directly translate to the patient in front of us. And this same issue applies in technology. A device tested in one hospital may perform differently in another with different workflows, staffing levels, or patient populations. Within these 3 broad categories, we may ask many sub-questions depending on the type of clinical question. If it's an intervention question, we may ask whether randomization was adequate. For diagnosis, we may ask how the test performed compared to the accepted gold standard. For harm, it may ask whether enough patients were followed to detect adverse outcomes. The type of study also matters. So, a randomized controlled trial raises different appraisal questions than a systematic review or an observational study, and each has strengths and limitations. So, for clinical engineers, the same 3 appraisal questions apply. Validity: was the device study free from bias? Did it use realistic conditions? And were performance measures collected fairly? Importance: do the results show a clinically meaningful difference? Does the new monitoring system actually reduce false alarms, or is the difference negligible? And we have applicability. Can the results be generalized to this hospital with this staff, this budget, and this patient population? In the lectures that we're going to follow, this we'll explore the different types of clinical questions, interventions, diagnosis, harm, and prognosis, and learn how to critically appraise studies and evidence that helps answer them. So this concludes the second part of evidence-based practice, evidence-based medicine. And to summarize, there are now many accessible resources to support evidence-based medicine. Over the years, the approach has evolved and it's best understood through the 4S model, or I would suggest starting through the 4S model, which is the hierarchy of evidence. And its foundation are studies, which are then organized into synthesis. Again, synthesis is just the plural of synthesis. I know I'm not saying that distinctly enough, but yeah, at least you can read it if you're seeing the slides. Um, and that's distilled into synopsis and ultimately embedded into systems that make evidence actionable at the point of care. And an essential part of this process is learning how to phrase the clinical question appropriately. The way a question is structured determines the type of evidence we seek and the strength of the answers we can find. For clinical engineers, this framework applies whether evaluating a new device, comparing competing technologies, or integrating evidence into hospital systems. Engineers also rely on studies, synthesis, synopsis, and systems to guide safe and effective practice. I want to thank you very much for listening to this presentation, and hopefully you will follow along with the next, this is two, I got 7, the next 5 in this series for evidence-based medicine.